Imagine this. Your daughter, partner, spouse is declared legally dead. Her heart has stopped beating on its own. Her brain no longer functions, but the hospital refuses to take her off of life support. Not because there's hope for recovery, but because she's 9 weeks pregnant. This isn't science fiction or a dystopian drama. It's the real life story that's happening right now. It's the story of Adriana Smith. She's a 30-year-old nurse in Georgia, and her case has ignited a national debate about reproductive rights, medical consent, and what it means to die with dignity in America. Welcome to the Black Doctors Podcast, where we examine the intersections of medicine, ethics, and justice. I'm Dr. Stephen Bradley. Today, we're diving into one of the most ethically complex and emotionally charged stories in recent memory. I am, by training, an anesthesiologist and critical care medicine physician. I've completed over a 2-year fellowship and several years of practice in the realm of medical ethics, and I am a healthcare ethics consultant certified through the American Society of Bioethics and Humanities. In my practice as a medical ethicist, I've consulted on a couple of similar cases, which I may reference during the course of today's episode. When and if I reference those cases, there will be some slight details that are changed to protect patient privacy and to protect their medical information. As you may have heard or read about in the news, Adriana Smith was a 30-year-old nurse from Georgia. In February of 2025, she was about 9 weeks pregnant when she suffered a devastating medical emergency involving blood clots in her brain. Despite intensive medical care, she was declared brain dead, a legal and clinical definition of death. So many times our patients' stories, unfortunately, in there, but in this case, despite this intensive medical care and the declaration of brain death, her family was not allowed to say goodbye. She remained on life support, not because there was potential for recovery, but because Adriana was pregnant. Her fetus still had detectable cardiac activity. Under Georgia law, you see, that meant the fetus has legal personhood, which overrides the family's wishes, which would override even the wishes of Adriana herself. Across the country, people are asking, how did we get here? So to understand this case, we need to understand brain death. According to the 2020 World Brain Death Project, brain death, which is more formally known as brain death or death by neurologic criteria, DNC, you may see that acronym. It is the complete and irreversible loss of all brain function. That includes consciousness, brainstem reflexes, and the ability to breathe independently. Determining brain death or death by neurologic criteria involves a rigorous clinical process. First, the patient must have a known cause of irreversible brain injury. We want to rule out confounders like different drugs or sedative medications, metabolic disorders, or cold, temperature, hypothermia. That has to be ruled out before declaring brain death. As clinicians, as a physician, we assess for the patients being in a coma and make sure there's no brain stem reflexes still there, such as pupillary response, gag reflex, cough, and there's no movement to painful stimulation. The final test is often the apnea test, where we pause the ventilator to see if carbon dioxide builds up in the patient's blood and if it will trigger them to breathe. If not, that confirms that the brainstem, which triggers us to breathe, is no longer functioning. There's other tests we can perform as well, such as imaging studies that will show if there is blood flow to the brain. In pregnant patients, we may skip apnea testing due to the risk of the fetus that is still alive or potentially viable. In the case of Adriana, ancillary testing, a nuclear medicine scan was used to confirm the diagnosis of brain death per report. Again, this is a case that is active and unfolding, so all of the information I'm speaking of comes from what's been released to the media. We can't share all of the details as physicians, and especially with these complex cases. So there is going to be some degree of error and even in this conversation, but I'll try to talk about some of the nuances because it's such an important case in such a tragic situation, because this does deal with real life people, real life families that are being devastated and fractured and harmed by what is going on. Let's talk about the ethics. So once a patient is declared brain dead, they are legally dead in every U.S. jurisdiction. So the question becomes, should we continue providing support to this life-sustaining measures? Should this be continued solely based on the fetus? You see, if there was not a fetus present, it's essentially required everywhere else that we withdraw life-sustaining support. There is no point. This is the extent of medical futility. This patient has passed away. They've died. They're not going to recover at all. And so we stop providing life-sustaining support. In medicine today, we can do things that we couldn't do 20, 30, 50 years ago. We have machines with ventilators that can continue to pump oxygen into and out of your body, can exchange carbon dioxide, can continue to have oxygen flowing. We can even replace the heart with machines like ECMO, which is extracorporeal membrane oxygenation. It's a machine that replaces the function of the heart and lungs and can use motors to pump blood throughout the body to maintain blood pressure, to maintain perfusion to vital organs, to maintain exchange of carbon dioxide and oxygen. These organs would be perfused. However, without a functioning brain, you are not alive. That is the death by neurologic criteria. From a medical ethics standpoint, there are 4 pillars of bioethics that come into play here. So autonomy, beneficence, non-maleficence, and justice. From an autonomy perspective, Adriana can't speak for herself, but she has family. She has her surrogate decision makers, and per reports in the media, they want her taken off of this life support because she is dead. Depending on the state, there's different rules with regards to surrogate decision makers. Oftentimes, if you're married, it would go to your spouse. There's nuances to all of this, and I've consulted on many cases where there's patients that were separated or divorced, and you have to find kind of who that appropriate surrogate decision maker is. Sometimes, if there's no spouse, it goes back to the parents or maybe to the adult children, but every state kind of has the order of succession. It's important to have conversations about what your wishes are should you pass away or be in a medical state where you aren't able to make decisions about your own healthcare. But it's highly, highly, highly unlikely any of us would have conversations about if I was pregnant and unable to speak for myself, this is what I would want done for myself, for the fetus. So we depend on surrogate decision makers to speak for that patient. Beneficence. Were we doing a good thing by continuing support, keeping this patient on life support? Beneficence means to do good, essentially. So you're looking at, I personally look at the patient that's in front of me, which is this mother who has passed away, who is no longer with us. The state of Georgia, as we'll talk about later, it seems they're focusing more on the fetus, the heartbeat that is still potentially viable within her womb, and choosing to treat that over or at the price or at the expense of the mother. There's a principle of non-maleficence, which is not doing harm. Are we doing harm to Adriana's body by keeping her not even alive, but keeping her physiologically stable to host this other organism or life? Are we doing harm to her family that is grieving, that has witnessed their loved one pass away and is witnessing them be essentially tortured, or her what remains of her life or her body is still being kept functioning through artificial means? And finally, there's the principle of justice. Who gets to decide what's being done? Right now, it's the Georgia legislature or Georgia law, but maybe not so much, because we'll get into that a little bit as we continue this conversation. What does the law in Georgia say about the rights of the unborn versus the wishes of a deceased patient or their surrogate decision makers? That's what's important here. And as we know, there's been sweeping changes to Roe versus Wade, and different heartbeat bills that are restrictive of abortion and maternal rights once the fetus has a heartbeat or after a certain number of weeks. And this is all kind of coming to a culmination with this situation. Studies show that nearly all hospital protocols fail to clearly define who is allowed to make decisions for a fetus in a situation like this. Is it the father of the baby? How do you determine who the father is with 100% validity? Is it the next of kin? What's the involvement of the hospital ethics committee? What's the involvement of the state and the judicial system? It's a very complex medical management. Some of the prior cases I've consulted on, one was another young lady who had lost consciousness and was in the teens, probably like 12 or 13 weeks along with her fetus. And this patient was not dead by neurologic criteria. We could not perform those studies and was actually just still had some hope for recovery. And ultimately we ended up providing supportive care while the fetus matured, is eventually delivering that baby by C-section. But in this case, the family was all on board. The spouse and other extended family believed that the patient's wishes would be to continue management and to ultimately deliver this child. So very different scenario here. But clinically, managing, and again, I'm a critical care physician, so I do manage patients that are in this level of sickness. Clinically, managing a brain-dead pregnant patient is complex. Think of it like caring for a deceased organ donor, except instead of hours, you're providing care for weeks or months. Some of the complications after death by neurologic criteria include cardiac arrhythmias, low blood pressures, or circulatory collapse, diabetes, and other issues with hormones, because you need an intact brain and neurologic system to function and manufacture hormones just for life in general, not even taking into account life when there's a developing fetus. You're prone to infections like pneumonia or sepsis, which is an infection in the bloodstream. Pneumonia, you're going to be on a ventilator for months until delivery. So there's a risk of that. With the risk of infection comes the necessitation of antibiotics. All of these medications interventions have some potential to harm that developing fetus. There's other risk of fluid in the lungs or low blood pressures and more. This means, again, we need thyroid hormones and other steroids to regulate the body's failing systems. We need medications to maintain blood sugar. That's very important in pregnancy as well. You need nutrition and the breathing machine to help support that not even patient, because this poor young lady has died. We are doing this to a dead body, keeping it physiologically stable to host this fetus. You typically need to perform a tracheostomy to maintain that airway long term, so a hole in the neck and moving that ventilator to the tracheostomy. In this patient's case, her fetus was just 9 weeks along, so very far from viability. They would need to provide support to reach that 24 to 28 week period where the fetus is viable, and this will be extensive, invasive, and uncertain if the fetus is still viable at this point, if what harm has been done between now and then. And again, this is all being done against the wishes of the surrogate decision makers, as stated in multiple reports on this situation. So what does the law say? After this case became public, a Georgia state senator reached out to the Attorney General for legal clarification. The Attorney General's office responded that there is nothing in Georgia's abortion law that requires a woman be kept on life support after brain death. They clarified that removing life support is not considered an act intended to terminate a pregnancy. Yet, it seems like the administration at the hospital with which she's being treated have reached a different conclusion. The hospital issued a statement saying their decision was based on consensus from clinical experts, medical literature, and legal guidance in compliance with Georgia law. So why the disconnect? When reaching out to other legal professors from other institutions, it was explained this way: in states with restrictive abortion laws, many physicians and institutions have become far more risk averse. In Georgia, for example, in the last year or two, there were 2 maternal deaths in the past couple of years that were ruled preventable due to delays in abortion care. So remember all of those, the consternation and when people were speaking out about the changes to Roe v. Wade and these heartbeat laws, and we talked about how these would negatively affect women and women's health and lead to death. It's happening. We said it was going to happen, and it's happening. Women are dying because these decisions on healthcare are no longer being made strictly between a woman and her physician. There's a whole legal impact that is causing harm. So in Georgia, you had 2 maternal deaths in the past couple of years that were ruled preventable due to delays in abortion care. So even when the Attorney General says you can act, quote unquote, hospitals are hesitant, worried about lawsuits, criminal charges, and just bad publicity or press, most likely. There's also the concept of fetal personhood. So in Georgia, embryos and fetuses are granted legal rights, so much so that they can be claimed apparently as dependents on tax returns. These laws, long a goal of the anti-abortion movement, are now being enforced, and they affect far more than just abortion care. They impact in vitro fertilization. They impact life and death decisions like those of Adriana. So what can we learn from this case? What can we take away? First, we need clarity, legal, medical, and ethical clarity around how to handle pregnancy after brain death. Second, we must advocate for reproductive autonomy. Laws that assign legal personhood at the point of cardiac activity can create medically untenable decisions and situations. Adriana Smith is legally dead. However, her body is being used as an incubator against her family's will. Finally, we need to acknowledge the role of racial disparities in reproductive care. Black women are more likely to experience pregnancy-related complications and less likely to have their healthcare wishes respected. The presence of pregnancy in a brain-dead woman poses difficult clinical, ethical, legal dilemmas, as mentioned before. We've gone through the ethical principles of autonomy, beneficence, non-maleficence, and justice, and understand that those affect both the woman, and then depending on who is part of the conversation, some also apply that to that of the fetus. It's a very rare event, and it's hard to really gather evidence in terms of what we should do. And evidence-based practice is very difficult. And then you add in the legal circumstances, it makes for very challenging decision-making, something that I've really leaned into and read and studied extensively to make sure we're doing the best we can for our patients. There's a paper in 2019 by Kardolovny et al. About this topic, and they propose some ethical and practical guidelines for managing brain death during pregnancy. Some of their key recommendations include confirming brain death and assessing fetal viability, consulting the father or next of kin, and considering the mother's previously expressed wishes. They recommend holding interdisciplinary meetings with physicians, caregivers, ethics committee members, and family to discuss the fetus prognosis and the broader emotional and financial implications. There should be some support provided to the family and make every effort to reach decisions within the clinical setting, trying to avoid court involvement unless absolutely necessary. Legal intervention should occur only if no consensus is reached or if the family's decision is deemed not in the fetus' best interest. It's interesting because this patient approaches it from the family's decision, where in this case specifically, it seems it's the hospital's decision to keep this patient on support against the family's wishes. While cost should be acknowledged, they should not be a driving decision maker in this conversation. And the study also recommended creation of kind of a registry to track these cases of pregnancy in brain dead patients. From an ethics perspective, it draws focus to the reason and need for diverse opinions and voices within the field of biomedical ethics. There's not too many of us. A good colleague, Dr. Berghart, she's out in California with her practice, and Dr. Kaplan is up out of NYU. He's quoted many times in literature, kind of a pioneer. Dr. Mark Siegler is at the University of Chicago, and that's where I trained at the McLean Center for Medical Ethics. But it is imperative that we take an active role as clinicians in these ethical decision-making conversations. This could all have been solved kind of earlier on in the process if the ethics committee there and other key decision makers had taken all these things into account and decided to do what is right for the patient. And by that patient, I mean following the wishes and recommendations of that surrogate decision maker who is now speaking on behalf of the patient, who is no longer able to speak for themselves. Adriana Smith was a nurse, a daughter, a person. Her story is not just a tragedy, it's a wake-up call. As physicians, ethicists, and the lay public, we must confront the reality of post-Roe versus Wade reproductive policy and ensure that our laws reflect compassion, consent, and clinical reality. Thank you for listening to this week's episode of the Black Doctors Podcast. As the third episode of the month, I try to share something from the field of medical ethics. This season on the podcast, the first episode of every month, deals specifically with creating that roadmap for people that are interested in becoming physicians. Whether you're an undergrad, pre-med, or just curious, one episode each month will kind of share the roadmap and tell you how you can become a physician. The second episode of every month this season is going to deal with advice and conversations specifically for physicians and healthcare workers, dealing with topics like burnout and career success. The third episode of the month deals with medical ethics. And then the fourth episode, I'm talking about anesthesia and gearing that episode towards the community. So if you have questions about the field of anesthesia, you can tune into those episodes and have your questions answered. I want to empower you as patients and your family members to know more about the field of medicine, specifically anesthesiology, because knowledge is power. I want you to be able to advocate for yourself when you're going in for these surgical procedures. So thank you so much for tuning in to the podcast. I'm Dr. Stephen Bradley. I do want to shout out one of my colleagues, Dr. Bianca Bush. She is a child and adolescent psychiatrist. She is the college psychiatrist, and she focuses her practice on mental health, especially for college students, those dealing with test-taking anxiety. To that end, we collaborated on a series of positive affirmations as you're preparing for tests or big life events. She reached out and I was able to create, I dabble in music. I created a 10-track ambient album to play as background music for her affirmations. I did release that on all streaming platforms back in February of this month. It's entitled Twice Daily Until Symptoms Resolve. It's an album of just peaceful, calm, quiet, ambient music. It's great to study to listen to as you're relaxing, maybe trying to take a nap or trying to meditate or do some mindfulness exercises. So please check those out, available on all streaming platforms. There's links in the show notes to both of these resources. Thank you so much for tuning in to the Black Doctors Podcast. I'm Dr. Stephen Bradley, your host, and I'm here because representation matters.